This next lecture will be on postpartum. The postpartum period, physiologically speaking, is the 6-week period of uterine involution. So it begins with the delivery of the placenta to the resolution of the anatomical and physiological changes that occurred during pregnancy, where all the systems return to that pre-pregnant state. Psychologically, it can take longer than the 6 weeks to accomplish this. The first acronym we're going to look at is BUBBLE-HE. And this is the focused assessment that you would do on your postpartum patient. Breasts, uterus and abdomen, bowel, bladder, lochia, her perineum, which may include an episiotomy or a tear, or her epidural site, the Homan sign, which we're going to look at her lower extremities to assess for DVTs and edema, and her emotional state. Physiological changes, like the reproductive system, will undergo some adaptation after delivery. The uterus will involute. Muscle fibers will contract after the delivery of the placenta, and this is what stops the bleeding of the large uterine vessels. You can massage gently the fundus, or the top of the uterus, to obtain that firmness, and it must be effective or clots can collect in the uterus. So this is a picture of the bleeding that occurred once the placenta was removed. And these are open blood vessels that have yet to clot off. So open blood vessels will continue to bleed into the uterus with every beat of the maternal heart if they're not clotted off by uterine contractions. So as the uterus contracts, that's what's clotting off these blood vessels. If that does not occur, postpartum hemorrhage would be the result, which is the leading cause of maternal mortality. Uterine contraction versus uterine atony, or when the muscle is not in a contracted state. So normal postpartum conditions with a contracted uterus would look like this, and one with uterine atony where it's not contracting will allow the blood to continue to flow, collect in the uterus, and then vaginal bleeding and hemorrhage. We want to make sure that we palpate the fundus as a postpartum nurse. So we usually start around the umbilicus. On days 1 or 2 is where we're going to find that top of that fundus, top of that uterus. Progressively, it gets smaller until it's not palpable anymore through the abdomen by about day 10. And this could take slightly longer with cesarean section deliveries. Be aware that a full bladder can move the fundus up and shift it to the right. Not only is it an inaccurate measurement of where that fundus is lying, but it also can prevent the uterus from contracting properly, and thus bleeding can occur. So we always want to make sure that we have our patients void before an exam. We always support the lower segment of the uterus with the opposite hand so that we are not pushing hard on the organs like the bladder or the uterus, so we don't want to have a prolapse. And we want to make sure that if there is atony or boggy or relaxed uterus, that we make sure that it is firmed up by uterine massage and that it is midline to the umbilicus. As we palpate the uterus, these are pictures of someone palpating the top of the uterus, placing their hand here to support the organs. And this is about where we will notice that uterus involute. So notice on the first day, it's right here about the umbilicus. That'll be where we feel the top of the uterus. Second day, another finger breadth down. Third day, fourth day, so on and so forth, until you can no longer feel the uterus because it's behind the bony architecture of the pelvis. So for nursing care, for uterine involution, the after pains and cramping can be intense with a postpartum patient. Multiparous, or ones who've had multiple deliveries before, or this is the second or third or fourth delivery of this woman, they can have worse contractions because the uterus needs to work harder to return to that pre-pregnant state than a first-time mom. So a multip may require narcotics for pain, like Dilaudid or Percocet, and not simply be able to just do with just Motrin, which is the typical medication we would prescribe for cramping in the postpartum period. The rubber band example is just that if you took a rubber band, a brand new rubber band, and you pulled it and then let it snap back, it would snap back pretty quickly. But if I pulled at that same rubber band consistently over a long period of time, it would get looser, it would lose some elasticity and kind of lose its shape. That's an example of how the uterus can be the more babies you have. It's just that uterus has been stretched and stretched and stretched so many times between pregnancies and contractions that it takes a little bit for it to snap back into place, if you will. So again, they may require a narcotic analgesic as opposed to an NSAID or in addition to an NSAID like Motrin. We want to make sure that our patients are voiding regularly. Remember that full bladder can prevent the uterus from involuting properly. Also, it's difficult at times for patients to be even aware that they have a full bladder in those first few postpartum days because of the abdominal stretching, because of anesthesia like an epidural or a spinal. Those can numb some of those nerves, and sometimes women aren't even aware that they actually have a full bladder. You can use a little bit of heat for cramping, although in some hospitals it's contraindicated against their policy. Contracting from the uterus or uterine involution will get worse when the woman is breastfeeding or the suckling of the infant. Because remember, as the infant is sucking on the nipple, it releases oxytocin. And oxytocin is what's contributing to making the uterus contract. And we would sometimes offer to pre-medicate our patients when we know that they are about to nurse, or we could give them Motrin ahead of time. And we want to make sure that education is critical, that our patients are aware of what this process is that's going on. There are different oxytocic agents that we can use to keep that uterus in a firm contracted state. We can use Pitocin, which we use during labor to help induce labor or augment labor by giving the uterus contractions, but we also use it in the postpartum period to again contract the uterus so that it can involute and clot off those blood vessels. Pitocin can be given IV, IM, or directly IU intrauterинely, like during a C-section. We can give something called Hemabate, which is an IM medication that will help with bleeding and contracting the uterus, but it is contraindicated if your patient is asthmatic. We can give a medication called Methergin. This can also be given IM or PO, but that is contraindicated with those who have hypertension, as the side effect can be to increase blood pressure. And then the last med we can do is Cytotec. This is a 200 to 1,000 microgram pill that we can give via the rectum and it melts and it allows the uterus to contract and help control that bleeding. So the puerperium, which is the 6 weeks after delivery, while the uterus is contracting, it's sloughing off its endometrium and a new layer of deciduum regenerates. During this time, there is lochia, which is the postpartum bleeding. And postpartum bleeding goes through 3 stages. Rubra, which is going to be bright red in color and will last the 1st to the about 5th day postpartum. The next stage would be serosa, which turns into a pink or tannish color bleeding, and that can last anywhere between 5 days to 2 weeks. And then the third is alba, which looks like a white or clear bleeding, and this can last for about 2 to 6 weeks intermittently throughout that time. So initially, lochia has a distinct smell to it. It's not foul like infection, but it is distinct. And small amounts of small clots are normal during this bleeding period, and one large clot can be normal after a period of a patient laying supine in the bed. The blood collects in the pelvis. And so if they get up initially to walk or use the restroom, it's not uncommon for a few small clots to drop or one decent sized clot to drop after they've been laying down for a while. This is the amount of lochia that we will determine on a pad. Based on looking at it, we would refer to it as scant, light, moderate, and heavy. So moderate is pretty common for the first few hours, possibly the first day of delivery. And then from there on, it really should start to become light to scant. That's pretty normal while the postpartum bleeding is going on. Heavy is never normal and never okay. So if your patient is soaking this type of pad like this, at least 1 hour, she's in a hemorrhage state. The placental site, which is now, the placenta has been detached and delivered after delivering the infant, this will heal by exfoliative shedding. So lochia, which is the postpartum bleeding, is a combination of these shed tissues, as well as blood, decidua, serous fluid, leukocytes, with the proportion of each changing as the lochia changes itself. And then the lack of scar tissue is important for future placental implantation in future pregnancies. And we talked a little bit about this when we talked about placenta previous. So scarring can affect where that future placenta decides to implant. The cervix will undergo changes. A floppy, or what we call patulous, is what the cervix will feel like immediately after birth. It can be visible at the vaginal introitus. It closes or firms as the uterus is involuting, and this takes about 2 weeks. The opening, or what we refer to as the Oz, will change its look permanently after the delivery of the first child. So initially the cervix looks round, and after the delivery of a first child, the cervix will always look like the second picture with a slit in it. The cervix is not routinely inspected for lacerations, although it can be lacerated during a delivery. A lacerated cervix can be the cause of continued postpartum bleeding if you have a firm uterus and you suspect that the bleeding is not coming from unclotted blood vessels, but instead from a laceration that has not been repaired properly. In the vagina, it will obviously be edematous from the pressure of labor as well as pushing after delivery. That may have lacerations that may or may not need to be repaired depending on the extent of them. And hemostasis and approximation need to occur in these lacerations. The smooth-walled feeling of the vagina can last for several weeks, and then eventually rugae begin to reappear. And the mucosa is thinned and drier, secondary to the drop in estrogen that occurs after delivery. This will continue until ovulation and menstruation resumes. So this is important to counsel for lubrication if patients want to resume sexual activity and find that it is uncomfortable or painful due to this thinning and drying of the mucosa and the drop of the estrogen. In the perineum, there may be lacerations or a purposeful incision like an episiotomy done to that as well. There are different degrees that a laceration or episiotomy can be made. A first degree is when it is mucosa only. The second degree is when it is mucosa and underlying muscle. The third degree is the mucosa, underlying muscle, and partial tear of the anal sphincter. And fourth degree would be the mucosa, underlining muscle, anal sphincter, and a tear of the anal mucosal capsula. So this is an example of the different tears. So this is a first degree tear. This is a second degree tear. This is a third degree tear. And you notice the fourth degree tear would go through the rectum. Obviously, we're worried about fecal incontinence when we are now tearing during that rectal muscle. So it's important that we are doing good bowel education for the patient after she has had an extensive tear. An episiotomy is a small cut that's made into the perineum, the area between the vagina and the rectum, to help widen the vaginal opening for delivery. Recovery can be uncomfortable and can be more extensive than a natural tear if the patient were to tear on their own. Just like a tear, it is at risk for infection and can cause pain during sexual intercourse when it resumes, and it can lead to fecal incontinence if the tear extends again through that rectum. Today, research has suggested that routine episiotomies are not necessary. So many years ago, it would not be uncommon for a practitioner to have you start pushing and immediately cut an episiotomy and then continue on with delivery. However, they have found that not every patient requires the vaginal opening to be widened. Maybe they've delivered before and they've had stretching of the muscle and of the fibers. Maybe the baby wasn't very big. So they don't do these routinely anymore, only if they're warranted. And they're warranted in cases where extensive vaginal tearing is likely to occur. The practitioner can see that she's already starting to tear on her own, or the baby's head seems to be bigger than average. If the baby is in an abnormal position, we can cut an episiotomy to kind of help with that delivery. If there's fetal macrosomia, where the baby is big, or if a quicker delivery is necessary, meaning that while she is pushing, there's fetal distress and they need to hasten the delivery quicker, they could cut an episiotomy to have you deliver in a quicker fashion than it would take you to naturally stretch your own perineum. So types of episiotomy incisions, there's the medial lateral and the midline. The midline is the most common. It's the one right here straight down. Obviously, this is the baby's head, so you would cut this opening to allow for more room. The medial lateral was designed to try to keep the tear away from going into the rectum, but I would say that it's the least of the two episiotomies. It's the least common due to the fact that healing is very difficult when it is cut in that fashion. So in the postpartum perineal care, this would include giving your patients ice packs, or what we call ice diapers, for at least the first 24 hours. Anything beyond that can impede healing and blood flow, so they don't really recommend it after the first 24 hours. Giving the mom a peri bottle, which is just filled with warm water that she can spray every time she uses the restroom or changes her pad to keep the area clean and free of infection. Dermaplast sprays and Duvocaine ointments, those are numbing medications that can be used for stitches or hemorrhoids. Tucks as well can be used for hemorrhoids. And all stitches that are given to a mom after a tear or an episiotomy will absorb on their own after about 2 weeks. They do not need to be removed. So nursing care will also include assessment of the perineal site. We assess for approximation, bruising, bleeding, edema, hematoma, and infection. We want to make sure that we are managing their pain by frequent assessment, positioning, and medication if needed. Proper nutrition to support and to prevent constipation, so encouraging lots of fluid and high fiber meals so that they are not constipated, straining to have a bowel movement, and then causing more discomfort or harm to the incisions. And exercise of injured muscles to improve blood flow and strength, like a Kegel exercise. There is a scale we use called the Rita scale, and this will grade the severity of the perineal trauma that was associated with mom's episiotomy or laceration after she delivered. And the Rita scale stands for redness, edema, ecchymosis, discharge, and approximation. The return of menstruation and ovulation can occur prior, so pregnancy can occur prior to this first menses because the return of menstruation and ovulation cannot always be predictable. So contraceptive options are an essential part of discharging teaching, because if mom would like to resume sexual activity but does not want another pregnancy while she's still recovering from this one, it can happen. So lactating women, we tell them that prolactin suppresses ovulation, and the return to menses can be unpredictable because of these prolactin levels. It can return anywhere from 6 weeks after you deliver up to a year or more. In a non-lactating woman, menses will usually resume about 6 to 8 weeks because the prolactin levels have now leveled off and it's no longer predicting when the menses will return or not. In lactating women, a sudden drop in the estrogen and progesterone with the birth of the placenta causes the increase in prolactin, which is needed for milk production. We want to be supported by frequent contact with baby or rooming in. This helps support that increased prolactin, but it will also suppress ovulation and delay menstruation. Now, some people feel that if they're breastfeeding, it's a form of birth control and they cannot get pregnant. In most cases, that's true, but there have been cases where you can still get pregnant even if you haven't had your first menstruation and you're breastfeeding. So the letdown reflex is when suckling occurs by the infant, causing oxytocin to be released, milk is ejected, and the uterus begins to involute. And this is what's also causing those after pains in the uterus, where we're giving ibuprofen, usually 600 to 800 milligrams depending, as our medication of choice. Breast milk we talked about before. The colostrum happens in the first 3 days, and that's that baby's first vaccine, if you will, because it's high in those IgA antibodies, very nutrient dense, and only small amounts are needed. And then we know that it'll eventually become transitional milk on days 3 to 6, mature milk after that, and the composition of milk will change over time. So with the breast, we want to make sure that we're palpating breasts to determine that they are soft or filling, that we can feel that the milk is coming in. Nipples should be soft as well, pliable, intact, and everted. We want to teach promotion of milk production and letdown, and methods to prevent and treat engorgement if that occurs. It can occur in the mammary glands by pressure exerted by synthesis and storage of breast milk, and it usually occurs when breast milk is changing from the colostrum to the mature milk. So once that full milk is coming in, that's usually when you'll see engorgement occur. Not often occurs when it's just colostrum. Abnormal breast findings would be redness, heat, pain, cracked or fissured nipples, inverted nipples, palpable masses, painful bleeding, bruising, blistering, or cracked nipples. In lactation, again, we know that in days 1 to 2, the breast will feel soft. We don't really feel the milk coming in yet, and then it will begin to start to feel firmer. On days 3 to 5, when that colostrum is changing over to transitional milk, the breast will feel warm and larger and a little firmer. We want to make sure that we're assessing nipples for intactness or damage or trauma at this point, because at this time the babies would have fed now for up to 5 days and could have been causing some trauma to that. At days 6 to 6 weeks, the breast will be full with the timing of the feed, and then they will soften after the feed as the baby empties the breast. Milk can spray or squirt out when the letdown occurs, and a crying baby or holding a baby can stimulate this process. After 6 weeks, the breast will remain soft even when they're full of milk. And again, examples of the different amounts and colors as the milk goes from colostrum to transitional to full milk. We talked a little bit about mastitis. I won't go over it again too much, but remember that that's the painful infection of the breast tissue. It can occur with bacteria, often from thrush from the baby, and it will give you this appearance of the wedge-shaped area, localized pain, redness, a firm nodule, definitely a high fever, and fatigue or exhaustion. In the bottle-feeding woman or the non-lactating woman, we still have colostrum that may leak. Remember, the body's going to go ahead and produce it automatically until it's given the instructions to stop doing so. So milk will still come in at about the 3rd day. And again, this can cause engorgement where the breasts get taut or erythematous or painful or even hot. It's safe to give Motrin for these cases. Ice packs or cold compresses, again, the tight sports bra, the green cabbage leaves, and to avoid breast stimulation or milk expression, as this will continue to make the breast milk. If you avoid stimulation, their prolactin levels will eventually drop and go down quickly when there's no suckling or stimulation of the breast. An increased duration of breastfeeding confirms significant health and developmental benefits for the child and the mother. As we've stated before, that breast is best when it comes to the IGAs and immunization. However, our job as nursing care is to educate our patients with this, support their decision, and encourage them on whatever they wanted to choose to do. The cardiovascular system, we know its increased propensity for clotting makes the postpartum woman increased risk for thrombi or blood clots. It's the perfect setup. She has increased blood volume, she has increased clotting factors, she may have been on bed rest during the labor with an epidural, she may have been post-surgical if she had a C-section. Her age can be a factor if she's over 35, her weight if she's obese, or if she has a history of smoking, or if she has varicosities. The body will prepare itself for delivery. So normal blood loss in a vaginal birth can be up to about 500 milliliters, and for cesarean section, it can be up to 1,000 milliliters. So 50% more maternal blood volume is causing that hemodilution and decreased hemoglobin and hematocrit. The natural reserve of blood for delivery can cause delay in hemorrhage diagnosis due to the atypical signs. So we may not be able to recognize that our mom is hemorrhaging until much later. It's difficult to assess how much blood is lost, so we assess risk factors as well as fundal firmness and lochia amounts. And the white blood cell count in the postpartum period can be up to about 20,000, which is normal and doesn't necessarily indicate infection. Vital signs, we're going to be doing vital signs quite frequently right after delivery, every 15 minutes for about the first hour, and then we go to every 4 hours, and then eventually Q shift or Q8 hours. A blood pressure of 140/90 can suggest postpartum preeclampsia. It deserves further investigation or evaluation. An orthostatic hypotension can occur as well because of the acute blood loss or dehydration that a patient may experience. So be careful when sitting a patient up or getting them to ambulate that they're at risk for falls. The pulse, because of the increased stroke volume due to the increased circulating volume and the placental uterine sinuses, can lower that pulse. And diuresis can occur. Less volume means that the pulse will eventually return to normal, usually by the end of the first week. Her temperature, you may see a slight increase in temperature, not a fever, but a slight increase in temperature in the postpartum period. And this is due to just the physical effort that she took to deliver, as well as dehydration, which occurs a lot during labor as well. Anything over about 100.4 degrees Fahrenheit would signify an infection. And on days 3 to 5, you may see a slight temperature increase. Again, not a fever, but a slight temperature increase due to the fact that the breasts are starting to engorge, and that can cause the temperature to rise slightly as well. As far as weight loss goes, you're going to see plus or minus about 12 pounds lost at the birth of the baby and the fluids and the placenta. Plus or minus about 5 pounds fluid loss from diuresis from days 2 to 5. 2 to 3 pounds lost from the shedding of the lochia. And the total by 6 weeks should be around 20 pounds. Extra weight can remain as fat deposits as mom is producing milk. The body will hold on to fat deposits to produce that milk. And lactating women need that extra calories, about 500 extra a day, to maintain this production of milk. In the integumentary system, women may appear about 6 months pregnant when they're standing due to the fact that the uterus is still overstretched and has not had the full time to involute properly. The skin and the underlying muscles are stretched. We talked about diastasis rectus may be visible. You may see stretch marks or striae that appear on the abdomen, the breast, or the hips, which will eventually fade over time. They do not disappear altogether, but they no longer look like the red stripes. They turn to a more silvery tan or white. The linea nigra that may have occurred due to the estrogen will gradually start to fade, may not disappear completely again, may have a faint line of it. In the conjunctiva, you might notice that the sclera may be pale due to anemia, or maybe even have a little bit of redness to them due to hemorrhage from pushing, or that little petechiae. Petechiae can occur in the face as well due to pushing. And then again, the skin around the perineum and the vagina may have lacerations. In the urinary system, it's often difficult for mom to sense that she has a full bladder, which we just talked about, due to edema, the decrease in the intra-abdominal pressure, and the effects of epidural and spinal anesthesia. And again, remember, the uterus cannot contract effectively if the bladder is full and in the way. The uterus will then deviate to the right with a full bladder. If a patient is unable to void on her own, catheterization may be needed, a straight cath or a Foley catheter, or if her bleeding is so big, if she's experiencing a postpartum hemorrhage, we will put a catheter in as well. And when we're having her use the restroom, we want to make sure that she's using we're running water to kind of help her pee. We're going to have her use the peri bottle to kind of squirt, not only to keep her clean, but that can sometimes stimulate her to be able to void. Sometimes an ammonia inhalant that's cracked and placed at the bottom of the toilet or the shower, if the mom wants to try to pee in the shower, which sometimes they have better luck doing that can sometimes help them go as well. Diuresis occurs where all the extra fluid volume from the pregnancy is now making a left space shift, and all that extra fluid doesn't know where to go initially, so it goes to the mom's face and her extremities. So she may look more swollen in her hands and feet and her face after delivery than she did when she was pregnant. However, this will only last for a short period of time, and then she will start to diurese all this extra fluid at about 12 hours postpartum. Gastrointestinally, she is at high risk for constipation. She still may have some poor abdominal intestinal muscle tone. She may be using narcotics for pain, which could contribute to constipation. She may have fear of passing stool due to the fact that her perineum is edematous or has lacerations to it. Hemorrhoids are common during pregnancy and pushing, so it could be hemorrhoids that are causing her pain, and she is fear of passing stool. So we oftentimes have stool softener regimens where we do kind of what we call anticipatory guidance, where we automatically order Colace or Seneca on a daily basis for our moms until that first bowel movement to help soften that stool. We'll have her increase her fluids and her fiber intake, and we really encourage ambulation. And if she does have any of those hemorrhoids, we can encourage her to use the Tux or the witch hazel for those. So emotionally, she has to now adapt to her new role. So in this new role, she will experience sleep deprivation, new physical demands, learning new skills like diaper changing, feeding, circumcision care, and learning the baby's cues and needs. So she's trying to learn this new person who she's now living with. So there are 3 phases of this puerperium that Reva Rubin described in 1977 that she says that all moms go through these 3 phases after they deliver. And she referred to them as taking in, taking hold, and letting go. The taking in phase is when mom is passive, uncertain, and still newly exhausted. She wants to be catered to and has others make decisions for her. So this is the very initial state where she may be okay with the nurse telling her, when the baby needs to eat, what the baby needs. She's allowing someone else to take control. She's going over the birth experience in her mind. She's exploring the new baby with unfamiliarity. She's touching the baby with fingertips, or she's very gentle to caress the baby or being very gentle near the baby. She may be taking this time to gaze at the baby on face. She's very vulnerable at this time, both physically and emotionally. And it's not really a good time for teaching because it's all about her. She's recovering, she's healing, she's resting. So this is where we can talk a little bit about what she needs to know, but we're also taking a big role in helping her do the things that she needs to do. In the taking hold phase, she starts to become more tentative, but she's building her confidence and gaining familiarity with her baby. There's now a strong interest in her taking care of her baby by herself. She's gaining familiarity and she still can feel a little unsure, but this is the time we want to give her praise and positive reinforcement that she's taking more independence and care of her infant. The letting go phase is when she starts to see that acceptance versus reality, or the acceptance of reality versus fantasy, is occurring. So maybe what she once envisioned her birth experience would be like, or her baby, or her body image, or her new role as it takes place as a mom, as a lover, or a spouse, or a worker, she has to accept that this is the reality of what it is, and it may be very different to what she thought in her mind it would be like. There may be grief or guilt over returning to work or having to return to work. She is gaining more confidence, though, and she's more independent in her actions in caring for the infant. She'll form her own opinions. So if a nurse comes in and says it's important that you feed the baby this way or at this time, she may say, well, I want to do it this way. She's forming her own ways of doing things. She usually initiates this after the hospital stay, but this is ongoing, and the duration is measured in years at this point. Bonding is important to make sure that our moms and our babies are bonding. And again, that's a picture of the on-face positioning. Baby talk is often used, which is that high-pitched sing-song way that a mom can talk to an infant, and that's called motherese. We'll start to notice that moms go from using their fingertips to their open palm to just exploring their baby fully. Entrainment is when the baby moves in rhythm with the adult speech. And we encourage rooming in to support all these bonding rituals, which is really essential. Unfortunately, emotionally, mom can have some other pitfalls during this psychological adaptation. And those are postpartum blues, postpartum depression, and postpartum psychosis. So postpartum blues, or what is commonly referred to as baby blues, is the normal effect of hormonal changes, life changes, and sleep deprivation. So this is the conflict between the expectation versus the reality now, and the physiological changes that are occurring specifically in the endocrine changes. So it usually will peak or get worse around 3 to 5 days, and it's characterized by a labile mood, tearfulness, and reality-based passing feelings of inadequacy. There's an early onset and a resolution to this. So these are when moms are really struggling initially. They don't feel like they're doing a good job. They don't know if they're being a good mom. And then really our goal here is to just encourage. This is a video that you are welcome to watch. I'm not going to play it right now, but it's just a fun little video to show you what baby blues may look like. And this is where your goal is to just keep encouraging mom that she's doing the right thing, that she, that this is not unusual, that, a lot of new moms feel this way, and then you just kind of keep being there to be supportive. She could experience something called postpartum depression, and postpartum depression is actually more severe than just a postpartum blues, and more than 3 million cases occur a year. This requires a medical diagnosis and needs to be treatable by a medical professional. This can take months to resolve, and it's important to tell your doctor if you've had a history of depression or postpartum depression in previous pregnancies. And the treatment can include therapy, medication, self-care, and specialists. And I will say with postpartum depression, it's less like a labile mood and more of a depressive state, meaning you're having a hard time getting out of bed or caring for yourself or even caring for the infant. So postpartum depression common symptoms can be changes in your sleep pattern, anger or rage at times, weepiness or sadness, difficulty concentrating, a change in your appetite, or you may notice increased anxiety. So this is a supportive group that helps women going through this, the Why Me. A lot of women feel guilt over this postpartum depression, which they cannot control, because they feel as if they were blessed with an infant or a healthy child, and they feel that this should be the happiest time of their lives, and why are they not happy? And so a lot of guilt and shame comes with this. So a lot of women have a hard time coming forward with the fact that they're feeling this way. Postpartum psychosis is a very severe variant of postpartum depression. It's rare, and it's a psychiatric emergency in which symptoms of high mood and racing thoughts, or what we call mania, depression, severe confusion, loss of inhibition, paranoia, hallucinations, or delusions may occur. The onset can be abrupt and sudden within those first few weeks, and the symptoms can vary and change quickly amongst all these. This requires emergency hospitalization and treatment. And the Andrea Yates case, I'm not going to go over right now, but if you want to look it up, it is a case of a woman who had severe postpartum psychosis and ended up doing harm to her children because she was in a delusional state. So postpartum nursing care, for the first 2 to 48 hours, we're a change agent, we're skilled observers, we're educators, we're expert time managers. We want to make sure that we're coaching them, that we are the scientists, we have the science behind what we're doing, and we're the caretakers there. We care by directing the knowledge of the stages of puerperium. So we want to make sure the mom's aware of the stages her body is going to be going through. We want to monitor her for safety. We want to do intensive discharge planning. There's a lot of education that goes into being a new mom, not only for her own body, but for her new infant. So there's a lot of discharge education that needs to go on. Repetitive anticipatory guidance. We want to make sure that we're increasing her self-care as well as her self-confidence. We want to increase the amount of independence she has with her own baby. And we want to make sure that we're closing or fixing any of those knowledge deficits that she may have. Special situations in the postpartum period may be a stillbirth. So many will move to a different floor other than a postpartum floor because they do not want to be around infants, but it still requires a lot of discharge teaching from the delivery. A death certificate will need to be filled out by the nurse and signed by the doctor. It may require that the baby needs an autopsy or a tissue sampling. You can help assist parents in funeral information, although you cannot make the arrangements for them. And there can be special markings on the door, oftentimes in hospitals a purple leaf, to signify that the mother has experienced a loss, so that a person coming in may not immediately think, since she's on the postpartum floor, come in, say congratulations. Maybe it's someone from dietary or from housekeeping. So we want to make sure that everyone's aware that there's a special situation going on in that room. Babies are kept available, if you will, on the unit for several hours. So if mother wants to visit with the baby, and sometimes we will bring the baby in for mom to hold or for family to see, we may keep the baby not in her room, but on the unit and available if she wants to see the baby again, or if she has other family members that come in at different times to see the baby. We try to dress the baby, we say, as attractively as possible. We put clothing on the baby, a hat. If there's any abnormalities or anomalies going on, we try to keep those hidden if we can. We will do pictures of the baby, footprints, a baptism if requested by the parents, clay models of the feet and hands. We really explore and encourage mom to touch her infant, keep these mementos with her. If she doesn't want to take them or if she's not in that mental state to do that, we'll often keep those mementos like pictures and footprints on file for a long period of time, because most often what happens is those moms who do not take it with them or are not ready to accept will call us at a later date and wish that she had. So we will keep those with us for a while in case she does. And we always do a follow-up call, visit, or some sort of follow-up to see that she's doing okay. Another A special circumstance could be if this involves adoption or surrogacy or surrendering the infant up for adoption. So immediately postpartum is not the time to reevaluate the decision making here. We want to make sure that we as caretakers are examining our own values, that we're not being judgmental of the decisions that the parents have made. We want to offer a private room, may or may not be on the maternity unit. We may want to give another room for the adoptive parents so that they can experience some of these stages of the Reuben described. And the ill infant. So if you had a mother who delivered an ill infant who required immediate transfer to another hospital or to the NICU unit, we want to make sure we encourage bonding as much as possible. Again, often giving them a private room, which is appreciated, that they're not sharing a room with another mom who has her infant with her. And we want to encourage her, if she did choose to breastfeed, to start initially pumping the breast so that when the baby is ready to eat, that milk is ready and we've started that process to pump the breast. All right, now we're going to move on to postpartum complications.